Okay, so we are already running late, so I would just not go in much details here. I would put two things which are important. So when we talk about leptomeningeal carcinomatosis, we're talking about a special disease here. We're talking about a disease which is now not restricted to the brain parenchyma, but is freely moving in the CSF. And because it's freely moving in the CSF, it clogs your drainage of your CSF, where it gets sucked in from the arachnoid, and that's how it leads to increased intracranial pressure, and that's how it leads to most of its effects like headache, vomiting, because the free flow of the CSF is lost. There is very limited literature about leptomeningeal carcinomatosis, and whenever I take a lecture, I like to do a PubMed search 1 or 2 days prior to this, and you could see that over the last few years, only 300 odd papers have got published. If this was for lung, that number would have been around 30,000 or 40,000. So that is that limited amount of literature. And if I restrict these results to what has come within one last year, that number comes down to 10. I'll just give an analogy. A similar research I did for my advanced esophagus lecture, which I took for my students last week. That number was at around 340 for randomized trials for 1 year. A similar search for lung would have again led to me around 4,000 odd articles. So understand that leptomeningeal carcinomatosis has very limited literature. Now you need to suspect that the patient has leptomeningeal carcinomatosis. It's common with lung cancer, it's common with breast cancer, and in melanoma. And when do you suspect it? You suspect it when the patient has these vague symptoms of raised intracranial pressures, or rarely, but sometimes the patient may come with some spinal nerve deficits also. Where do you get your clues that the patient probably has leptomeningeal carcinomatosis? It's when you do your imaging. As what was shown by Dr. Amit Janu in his initial slides, if you look for the IV sign, where the sulci, which normally that area is gray, if that area starts becoming bright on post T1 contrast imaging, you start thinking that this patient has leptomeningeal carcinomatosis. Now, how do you diagnose or say that label a patient? You suspected that the patient may have leptomeningeal carcinom. How do you label that this patient has leptomeningeal carcinomatosis? You look at three things here actually. You look whether the patient has a CSF cytology which is positive. You look at whether the patient has any clinical or neurological features of leptomeningeal carcinomatosis. So if the CSF cytology is positive, which is the upper half of the table, whatever would the findings on MRI, you would say that the diagnosis of leptomeningeal mets is confirmed. If your cytology is negative or equivocal, and if your MRI shows these patterns, that is linear enhancements or nodules or linear plus nodules, then you start saying that the diagnosis is probable if the patient has, with these MRI features, the clinical features also. You can also have a possible diagnosis where there are equivocal features which are coming. The patient has typical clinical signs, but your repeated CSF examinations are coming negative and the MRI is not showing typical features of leptomeningeal disease. So understand, we are looking at a disease segment here where getting confirmed reports of leptomeningeal carcinomatosis is possible only in 30 to 40% of the patients. A wide majority of 40 to 50% would have probable disease, and in 10 to 15% you would also have something what is called as possible disease. Now let me warn you, when the patients are taken for studies of leptomeningeal disease, you take patients both which may have confirmed disease or probable disease, which means if the patient has a CSF positivity, or if the CSF positivity is not there, patient has clinical features, but and the MRI also shows that there are features which are linear enhancements or nodules. So this is what you would do and these are the examples. I think the slide would be visible where you could see that there is folial deposits which are there. You could see that there is this enhancements which start increasing, and this was what was taught to me by Dr. Shetty in one of the JNMs, that if you see this enhancement which normally also go in the vessel, they go for around 1/3 of the area. If they go more than that 1/3, that's the time you start thinking about A. And normally when you look at an MRI post T1 contrast, you don't appreciate that there are enhancements. If you start appreciating that a lot more enhancements have been seen, that's time you start looking for features for leptomeningeal carcinomatosis. This is our own data, and you could see that out of 1,148 patients which we took, only 36 had developed this. And these are the patients which were on some of the other clinical trials that pull out this data. The median survival in this situation is dismal. You could see that it was only 61 days. So what I'm trying to tell you is that even in study patients who develop leptomeningeal metastasis, the outcomes are poor. Who develops it when you look at specifically with lung cancer? There's a patient positive status, they develop more amount of leptomeningeal disease. And patients who had previously had brain metastasis, they also subsequently tend to have more of leptomeningeal disease. And if you look at the survivals in all segments are dismal. If you see, this is what is reported across literature. It will be between 1 to 4 months. So the goals of your therapy when you look at such poor survivals is first to get a good quality of life, keep the patient symptom free, and the last is to try to improve their outcomes. Now, the traditional thinking is that if there's leptomeningeal, there's something in the CSF which is swimming across the CSF. Let's try and give intrathecal therapy. There are multiple agents. We commonly use something called as methotrexate. Cytarabine has been used. Liposomal cytarabine has been used. And these are the schedules which are there, and I won't go in the details of this. So let's ask us a few questions to understand this disease better. Let's ask the first question. Okay, intrathecal therapy makes sense. You give it either via lumbar puncture or via the Rizzo wire. It goes directly to CSF. But does it help your patient? Now, the issue is there are very few randomized studies which are done in leptomeningeal disease. And most of the studies have patient numbers which are in early 2 digits, like 40, 50, such kind of numbers. And none of them have been done in lung cancer. So this first study for breast cancer clearly showed that whether you give intrathecal or you didn't give intrathecal, it didn't matter. The local controls, the progression-free survival, the overall survival were similar. This was this study which came, this is the second randomized study which came. And this again is in breast cancer. And it gave intrathecal liposomal cytarabine. Now this study was actually reported as a positive study. And what that reported is a leptomeningeal progression-free survival. You could see here that there was improvement in the leptomeningeal progression-free survival from 2.2 to 3.8 months. Sorry, not a big improvement, but that's what they saw. The overall survival and the overall progression-free survival were similar between the studies. Now you could argue that there's not much improvement in OS or PFS with intrathecal therapy. There are some amount of modest benefits with leptomeningeal progression. Should we even consider giving intrathecal therapy or not? And that's a good argument to have, and you could see the glass both ways. I would say that if you have some local therapies and for something like brain or for intrathecal for leptomeningeal, their impact on extracranial disease are going to be limited. So their evaluation needs to be with some local endpoints. The other way around, you would also say that the patient has a lot of pain while giving repeated intrathecals. Quality of life deteriorates. Why don't you give that? And so both arguments are okay, and that's the reason why we have a divide where some people may not give intrathecal therapies in patients with leptomeningeal metastasis. Do we have such any study in lung cancer? As I told you, no study in lung cancer. Those are the only 2 randomized studies and small randomized studies done in breast cancer. This is this very good data which has come from China, and what it shows is that when they did a match pair kind of an analysis, there was no benefit of intrathecal therapy for overall survival. Though some amount of neurological improvements were seen with patients who received intrathecal therapy. And so what would you conclude with intrathecal therapy? So there's some limited amount of benefit with intrathecal therapy. There's limited data which shows that you could get some modest benefit with intrathecal PFS, but not much benefit with overall survival. The question comes, which of the intrathecals would you want to give? Do you want to give a single agent intrathecal, or you want to give a triple agent intrathecal? People always thought that combining more drugs would be more effective. Don't bother, the study was negative. So single agent intrathecal is as good as doing combination intrathecal. People tried replacing methotrexate with thiotepa, and more or less again the conclusions were similar. What actually showed that it may improve slightly its outcomes over intrathecal methotrexate was a sustained release cytarabine, where modest improvements in sustained release cytarabine when was given led to improvement in intrathecal methotrexate, but the improvements were seen in progression-free survival. They were at the best, I would say, modest, where 80 days went to 105 days, but overall survival remained the remained nearly same. So the question comes as, okay, you said that for that modest benefit, you want to give intrathecal therapy. You want to either choose methotrexate or depot preparation of cytarabine or a sustained release cytarabine. How do you want to give it? Whether you want to give it with IP or you want Dr. Prakash to put a reservoir and you want to give it via the reservoir punctures. The problem is we are looking at a disease in which the outcomes are, I would say, dismal. Most of the patients die within 4 months. And so would you want your patients to be going through such a neurosurgical procedure? And what it did show is that when your drug which you gave has a short half-life, that it's like becomes relevant. Giving via reservoir might be beneficial. If you're going to give a sustained release cytarabine, or it is irrelevant. But again, the improvements which were there were very modest to most of the extent, and most of the people would still want to give it intrathecally as not with a reservoir, because that means that patient has to undergo an additional procedure in a patient which has a dismal prognosis. Now, most of the time, things like there was what Dr. Asha was pointing out at that immunotherapy might not reach your I thought that this was an excellent study which was done in such a rare situation. This was actually an investigator-initiated trial. I had asked BMS for the details, and that time they told me that it was an investigator-initiated trial and was done by Dr. Glitza from MD Anderson, and looked at patients who were treated with these doses of immunotherapy, which were 5 mg, 10 mg, and 20 mg. And what they showed was that 20 mg was a tolerable A. Mind you, these results are applicable and was tested in, you could vouch for the safety as the human species remains same whether they have melanoma or lung cancer or breast cancer. But the efficacy wise, in melanoma, in combination with, where there was BRAF mutation, they had given BRAF inhibitors, that show that immunotherapy had had some promising outcomes, with the median OS was around 46 weeks, that is nearly tending towards an year, which initially used to be around 4 months. A word about intrathecal therapy for HER2 positive breast cancer. So that there is phase 1 data which shows that you can give intrathecal trastuzumab, and the dose of intrathecal trastuzumab which they had seen and proposed was around 150 mg, and it does show that with 150 mg of trastuzumab you could have some amount of clinical response in these patients, and this response remains sustained also. And how was this given? This was given once a week for 4 weeks. So it's important that we realize and start working on this, that intrathecal therapy, we need to see how can we give targeted therapies also intrathecally. Can we, Nandini spoke a lot about systemic therapy and good penetration with them, and whether we could look at same thing as an answer for leptomeningeal also. Unfortunately, the first generation TKI, whether it's for EGFR or ALK, they have limited CNS penetrations. And because they are limited CNS penetrations, you would also expect that they would have limited effectiveness in leptomeningeal carcinomatosis. There's one of the phase 2 study which got published in Oncology, which actually showed that erlotinib is not that bad either. If you give erlotinib, it can give you around 30% clearance rates. And would giving a high dose of these drugs would lead to better CSF concentration? Vikram sir has done that study, and yes, it does show that giving a high doses of these drugs could lead to a higher CSF concentration, and probably that may translate into better outcomes in these patients. Osimertinib, I would focus on EGFR mutation here. Osimertinib plus bevacizumab for leptomeningeal metastasis. This was a good study, and they did one of the rare studies in leptomeningeal carcinomatosis in which you could see that the curve for survival is going beyond 2 years. that is not seen. Most of the time the curves is somewhere stops between 6 months to 1 year, suggesting that this strategy of using osimertinib plus bevacizumab in patients who have leptomeningeal carcinomatosis may have better outcome. What if you try to use osimertinib alone? And this was the data we got from the Bloom study, in which they looked at osimertinib alone in leptomeningeal metastasis. And look at the response rates. That by independent was around 62%, and by the investigator was around 27%. So one thing which I wanted to point out is that this happens in the real world also, that some radiologists may think this is stable disease, some may think this is PR, this is subjectiveness, and this would happen always, that you would have difference of opinion among two equally trained physicians. But what I'm trying to point out is that if you look at the duration of response, that was in the last column below, it's around 15 months, 18 months, 90. So a few minutes back I told you the survivals of 4 months. So in mutated diseases, when you give osimertinib, they derive a very good benefit from these drugs. So as I told you, the higher dose may have better penetrability. What about giving 160 mg dose of osimertinib and trying it? Had a good response in the study. Intracranial disease control rate was around 92.5% when you give higher dose. For me, what was an important takeaway from this study was that this B figure, I cannot move the B figure. What this shows is whether the patient had received previous treatment or not, and this leptomeningeal cohort is there, and whether the patient had a T790M mutation or not, irrespective of the mutation and irrespective of whether the patient was treated previously with a TK or not TK. When you give higher doses of osimertinib, that seems to have a better impact in leptomeningeal disease. Now, I told you that there is very limited evidence about doing whether we give, when we have good TKs giving good benefits in lung cancer in driver mutated, whether adding a intrathecal would benefit or not. This is a study which, as a DMG, we had proposed. This just got IC approval 2 days back. Dr. Gota sir is also part of this study, where we are going to look at patients with leptomeningeal carcinoma of lung cancer and randomize them between TKI versus TKI plus intrathecal methotrexate, and would answer that golden question, whether in today's era of having very good TKIs, whether giving intrathecal methotrexate adds or not. Along with that, what we propose to do is, with this limited data about CSF levels of this patient, so sir is going to look at the population pharmacokinetics of these drugs to plot us curves for looking what is the level of this drug in the CSF, and if you could come with some predictive models also that which are the patients do better and how they will. We are also going to look at quality of life. The talk won't be complete if I don't talk about immunotherapy. And as I do that, there is a good amount of things going where we have some trials which have shown that if you try single agent pembrolizumab and leptomeningeal carcinomatosis, you would get some benefit. And the reason why I said some benefit, you look at the median OS, it's 3.6 months. So the success of immunotherapy has not got replicated in leptomeningeal carcinomatosis, but it doesn't say that it is not useful. The multiple case reports, and I've enlisted them, where patients with leptomeningeal carcinomatosis, when treated with nivolumab, have got sustained remissions and have gone for years together. So at present, we don't know in which patients immunotherapy would benefit for leptomeningeal carcinomatosis. The day we know it, we would be much more wiser and we would choose our patients appropriately. This is a complicated diagram by ESMO. I don't like it, so I made a simplified one for you. Patient at poor risk, poor performance, significant neurological deficit, or has very advanced disease and doesn't have any good therapy. Let this patient go home. Do not trouble this patient by giving any extra investigation or any therapy. If the patient has absence of these features, then you start thinking of treating this patient, and that would be by systemic management and intrathecal management. So I'd conclude that prognosis remains dismal in this, and I believe that more research would help, especially with having more targeted therapies in this area. With that, I would conclude my talk, and if anyone has any question, I am happy to take.